Gupta, for giving me the opportunity to present this particular session in this prestigious conference. So my topic is basically on the more highly prevalent disease in cardiology, which is heart failure. And out of heart failure, a little we can say the neglected component of heart failure is the heart failure with the preserved ejection fraction, or you can say the underdiagnosed disease amongst the heart failure patients. So I'll be discussing under these headings. Basically, I'll be discussing the newer concepts which are coming up in terms of heart failure with preserved ejection fraction. So the concept of preserved ejection fraction started very early when there were numerous trials for the heart failure with reduced ejection fraction, which included less than 40%. So initial trials they started including ejection fraction more than 40% in the form of CHARM preserved trial. And then recently we had Emperor Preserved Liver trial, which included again less than 40%, more than 40% as a other than reduced ejection fraction. Then I Preserved trial, which included patient more than 45% of ejection fraction as a patients without heart failure reduced ejection fraction. Now universally we divide heart failure into three categories as per the ejection fraction is concerned, and our topic is basically heart failure preserved ejection fraction, which will be including heart failure with ejection fraction of left ventricular more than equal to 50%. So that's how the evolution of ejection fraction in terms of preserved ejection fraction or mildly reduced ejection fraction has came up. So why do we need, there is a continuous evolution of heart failure management strategy. As we know, the need is basically is primarily driven by the disease prevalence in the community. So globally, we can see the prevalence is about 1 to 2%. Even in India, the prevalence remains same. But in 2016, the data which has shown that 8 to 10 million patients population is having heart failure. Globally, the prevalence of heart failure with preserved ejection fraction is almost equal to heart failure reduced ejection fraction. But various Indian registries has shown that the heart failure with reduced ejection fraction is to the tune of 60%, and the preserved ejection fraction is about 35–40%. So probably we are underdiagnosing HFpEF patients, and the 30-day mortality is to the tune of 12 to 14%, and 1 year mortality is 25 to 30%. It is not about the mortality. Even the morbidity is very high in terms of repeat hospitalization and the daily cost of living and the medication. So these are the data which has shown, as we can see that the Indian mortality, 1 year mortality is to the tune of around 25 to 30% in 1 year. These are the international data where India has component in one of the trials. And below we can see our own Indian heart failure registries. And the latest one to 2022 and 2022, one National Heart Failure Registry and the Indian College of Cardiology National Heart Failure Registry, and we can very well see the HFrEF patients are more. So what we feel, probably they are more in proportion because HFpEF is little less diagnosed and undermined. It is considered maybe less important. So why those things are there, we will see. How HFpEF is different from HFrEF patient. They are more elderly, they are more comorbid. About 70% they have coronary artery disease, they are hypertensive, diabetic. So the combination of diseases is more common in patients with HFpEF patient as compared to HFrEF patient. They are anemic, obese. Obesity with HFpEF is far common as we think in our OPD practices. And atrial fibrillation is more common to the tune of 44%. And in this slide, we can see these patients are overall far more comorbid than HFrEF patients. And another thing which is shifting nowadays, rather than considering HFpEF as a disease, we consider that it as a heterogeneous syndrome. So there is a concept of HFpEF phenotypes. Rather than saying that this patient is having ejection fraction of more than 50% and the BNP is high, and we are just treating heart failure in the form of fluid overload and that particular scenario, we assess the pathophysiological aspects of HFpEF in terms of the associated comorbidities, the biomarkers, by doing more and more cardiovascular imaging of CT, CMR, and hemodynamics, and then we try to divide those pathophysiological factors into the phenotypes. So we see that based upon comorbidities, we can divide HFpEF into obesity related, and which is probably the most common phenotype of HFpEF syndrome. And we see, rather we see an obese patient with dyspnea, our first sorry, our first thought is probably this patient could be HFpEF, and we go for echo. Then the other, based on comorbidity, the second component is the coronary artery disease, and then the microvascular, coronary microvascular dysfunction scenario, where you can have normal epicardial coronaries, but you have microvascular dysfunction leading on to HFpEF. Coming on, based on pathophysiology, you can have systolic dysfunctional phenotype associated with coronary artery disease or microvascular dysfunction. Left atrial dysfunction phenotype, it's an upcoming thing. Again, atrial cardiomyopathies are newer upcoming things. Then you have pulmonary hypertension, pulmonary vascular diseases, and right heart dysfunction. Chronotropic incompetence, like bradycardia patient, they present with HFpEF, with LVH, and this is the based upon pathophysiology. You can have these classification. So this is a nutshell of the overall pathophysiological process of HFpEF. So as we can see, this is a multifactorial combination of various comorbidity and pathophysiological changes, not in the heart, but in the blood vessels, even in the skeletal muscles at the level of vessel wall as well. So there is a concept of as to how do we evaluate these patients. So age-old definition of HFpEF will be you have the clinical symptoms, ejection fraction of more than equal to 50%, and you have the evidence of increased filling pressures of left ventricle, which could be invasive element or a non-invasive evaluation. And the basic hallmark of HFpEF will be the raised filling pressure of left ventricle. But there is a diagnostic challenge for the HFpEF patient. Why that is so? If we just rely on the biomarkers or echocardiography, we'll be missing some of the patients, because echo is less sensitive to diagnose LV filling pressures, or sometimes these are not checked, and the BNP level may be low in some of the HFpEF patients. Again, if you are just diagnosing on the basis of these levels, we may miss some of the cases. Even in patients meeting diagnostic criteria, symptoms may also be related to other conditions such as anemia, obesity. So these are all competing interests or the symptom producing associated findings which can be produced. So you may be over-diagnosing sometime. Most of the time you are under-diagnosing, but sometime your symptoms might not be related to HFpEF, but related to these competing syndromes associated with HFpEF. So they have come up with a newer diagnostic algorithm for the management of HFpEF, where you have the patient of dyspnea under evaluation with ejection fraction of more than equal to 50%. Then you see the Bayesian probability, that whether this patient is at a low risk, intermediate, or a high risk. For those probability, they have come up with two scores, H2 HFpEF score and HFA PEF score. Based upon these are clinical. These scores are based upon the clinical, the biomarker, and the echo findings. So all these things are going to be the non-invasive evaluations. So you have a patient ejection fraction more than 50%, you go for these probability score. Out of these, the first one on the left side, H2 HFpEF score, is more commonly used. You have the score system, then you can label that patient as a low, intermediate, or a high probability. If it is a low probability, you rule out the diagnosis. If it is a high probability, you rule in the diagnosis of HFpEF. And you have intermediate probability. There you can further go for the exercise stress testing, which could be non-invasive or invasive. So non-invasive, it is like diastolic stress testing you can go for. But mostly, if you follow this, you will either rule in or rule out the diagnosis of HFpEF. And very less number of patients you will have intermediate probability. So apart from this, you should be aware of some of the conditions, clinical conditions, which are mimickers of HFpEF, which are valvular heart disease. Obviously, that will be ruled out by echo. Pulmonary hypertension again can be ruled out by echo. Pericardial diseases, right ventricular dysfunction, sarcoidosis, HCM. Some of the things will be mostly ruled out by echocardiography, and some will be further ruled out by other imaging modalities like cardiac MRI. Then what is the evolution in the management concept? Till now we were like HFpEF management is just like a diuretic, and in the heart failure reduced ejection fraction, you have 4 pillars of management of heart failure. Everything was focused on the HFrEF patients. Now there are newer things which have come up in HFpEF management. So it has got poor prognosis because of increased proportion of non-cardiac causes of mortality. And reduced cardiorespiratory fitness, and quality of life is far poor compared to HFrEF patients. So we have 3 modes: non-pharmacological, pharmacological, and device-based management strategies. So in the non-pharmacological, we have cardiac rehabilitation program, which includes the moderate intensity continuous exercise training. As per the functional capacity, you can ask the patient as to follow one of the protocol for the cardiac rehabilitation, and the dietary interventions in the form of calorie restriction, intentional weight loss, because most of the cases they are obese with HFpEF scenario. So these cardiac rehabilitation will increase the VO2, improve cardiac output, cardiac function, improve ventilatory efficacy, and other way, and eventually improves the quality of life of patients of HFpEF. Amongst the dietary, it's a routine with the reduced salt intake and increase in protein intake, and saturated fats should be, so routine DASH diet and Mediterranean diet has to be followed. Then coming to the pharmacological, which is most important nowadays, has been studied too much. The optimization, most important will be optimization of the comorbid illness like hypertension management. You have set goals for the management of hypertension, CAD management, atrial fibrillation, and appropriate management of diabetes mellitus. And more importantly, you have a SGLT2. The coming up things are SGLT2 inhibitors, ARNI, GLP-1 analogs, and non-steroidal mineralocorticoid receptor antagonist, which is finerenone, the latest one in 2024. So this is how the journey of SGLT2 started. First they studied in diabetes. We are more concerned with these 2 trials which have changed a major paradigm change in the management of HFpEF patient, with the empagliflozin and the dapagliflozin, which have reduced the combined risk of CV death, hospitalization for heart failure in patients with heart failure, and preserved ejection fraction, regardless of the presence or absence of diabetes. This is a breakthrough in the management of HFpEF patient. Previously, we already, everyone knows the HFrEF management. We have 4 pillars: ACE inhibitor, ARB, ARNI, SGLT2, MRAs, and these beta blocker, and nothing was there with the HFpEF patient. So this is the first, this is a breakthrough medical therapy which has been labeled as class 2A indication, and probably in near future it will rise up to class 1 indication as well. So this becomes the first pillar of management of HFpEF patient. There comes the role of ACE inhibitor, ARB. There were a number of trials right from the beginning. Previously they studied charm preserved in more than 40%, 45%, then PEP, perindopril ACE inhibitor trials. Now the recent one, the Paragon HF and Parallax trial, where they have studied the role of ARNI in HFpEF patients. But overall it was not positive. So in one of the subset, it was found that the subgroup analysis showed the benefit was there in relatively, not in all patients with normal ejection fraction, but ejection fraction less than 57%, and in females it was found to be beneficial. So thereby the indication, the class of indication is not class 2A for ARNIs or ARBs or ACE inhibitor, it is class 2B indication. Probably the future will guide us further to whether these are still beneficial or not. It is under process. There comes the role of mineralocorticoid receptor antagonist, is one of the important pillar for the HFrEF patients. In the meta-analysis, they have found the steroidal MRIs, like the aldactone, spironolactone, reduces the risk of CV events in HFrEF patients, but non-steroidal MRIs, which is the latest one, the finerenone, reduces the risk of patient with mid-range as well as preserved ejection fraction. So TopCat studied spironolactone, and the latest one, which was presented in 2024 ESC Congress, which has shown reduce the primary endpoint, and this will become probably the second pillar for the management of HFpEF patients. So this is an important molecule. Then comes the role of the finerenone could be a second pillar after SGLT2 inhibitor. Presently, till now, it is class 2B indication to start MRAs. Then another drug, which is semaglutide GLP-1 analog, the latest trial has shown STEP heart failure trial in preserved ejection fraction on obese patient. It has shown to improve the cardiovascular events. So in near future, this is another molecule which probably will come as a management of, in due course of coming years, in the management of HFpEF patients. So now we have numerous, at least 2 to 3 drugs which could be beneficial in reducing the heart failure hospitalization in HFpEF patient as well. Then there is a concept, devices which are being studied for HFpEF patients. So basic pathology for HFpEF is LV dilatation or LV hypertrophy or autonomic imbalance. So you are dealing LA dilatation by producing intraatrial shunts to decrease the LA pressure. You have atrial shunts to expand the LV volume. You have left ventricular expanders, and then you have a stimulation therapies for autonomic imbalance. These are all under trials, but these are there. So various modes of device therapies are intraatrial shunts, implantable CPWP like left atrial pressure monitors, the cardiac contractility modulation, renal denervation, baroreflex activation therapy, vagus nerve stimulation, and splanchnic ablation therapy. These are all device-based therapies which are being studied for HFpEF patients. So these are the trials which has been done for atrial shunts, for the CardioMEMS or the remote monitoring of pulmonary artery pressure. You put in these CardioMEMS in the pulmonary artery invasively, and you just have data with you as how's the pressures monitored, and then you manage those patients or alter the therapies by using these techniques. So you have trials. The latest trial is a positive trial for, that is Monitor HF 2023 trial is there. And then you have Optimizer Smart, that is CCM. These are all modulators which modulates the function of the heart. Then you have various other modes. These are all therapies which are under trials, which might come as later on as FDA approval and maybe class 2A indication later on. So take home message for the HFpEF patient is basically the HFpEF, we must understand it is not just a disease, it is a heterogeneous syndrome with various phenotypes. So you try to classify those patients into obesity related or coronary artery disease related, or according to pathophysiology, whether LA is more abnormal or left ventricular hypertrophy component is produced. So you have to classify that particular syndrome into particular phenotype. And then there is evolution in the form of these scores which are crucial for the diagnostic accuracy so that we don't miss HFpEF patient. That's why probably in Indian registries, the component of HFpEF is less compared to HFrEF. So overall worldwide, because they have better diagnostic algorithmic strategies, so there it is 50-50%. In India, it is like 60-30%. Then we have emerged SGLT2 inhibitor as a breakthrough first pillar for the management of HFpEF patients, and finerenone is likely to come up as a second pillar, and following that, ARNI and semaglutide are already in line and are being studied in the this thing. And the potential device therapies are still in the experimental stage. So thank you.
Thank you very much, Dr. Bhupinder. Great talk. And heart failure with preserved ejection fraction, I think it is coming up in a very big way, and people are being sensitized by lectures like yours to look for heart failure with preserved ejection fraction. Otherwise, it is a neglected entity and nobody is caring about it. Definitely. And with introduction of SGLT2 and other modalities, so it is good to have patients under control and being treated great. Yes. Thank you very much for your enlightening talk.
Thank you, sir.
Any questions? Thank you.